In May 2021, the National Cancer Institute convened a two-day virtual meeting that brought together experts in research and clinical care to discuss the survivorship needs of individuals living with advanced and metastatic cancers. The meeting included a panel of 4 cancer patients and survivors who discussed their experiences living with advanced or metastatic cancer. All the panelists are passionate advocates for the cancer patient community. Christine Hodgson moderated the panel. Christine was diagnosed with metastatic breast cancer in 2015 and is an advocate who co-founded GRASP, an organization that empowers advocates and scientists to learn from one another to drive more meaningful research. Panelist Bethany Ross Abbott was diagnosed in 2018 at the age of 30 with stage 4 neuroendocrine cancer in her appendix and pancreas that spread to her lymph nodes and liver. She will need to monitor the disease for the rest of her life, but today has no evidence of cancer. Bethany works full-time as an information security engineer and enjoys cancer advocacy and running marathons. Panelist Leslie Kailani Glenn is a native Hawaiian and the founder and CEO of Project Life, a virtual wellness house that bridges the gap in survivorship for those living with advanced breast cancer and their loved ones. Leslie has lived with advanced breast cancer herself for 8 years and is a passionate advocate for the metastatic breast cancer community. Panelist Lee Jones was diagnosed in 2004 at the age of 55 with metastatic colon cancer that had metastasized in his liver. After years of treatment and monitoring, he has been cancer-free since 2011. Today, Lee is committed to promoting the patient voice in cancer research, treatments, medical care, and the healthcare system in general.
I'm very excited to be here today, and I'm very excited to host this excellent panel that we have. I think we've already had a really rich discussion about the needs of patients living with advanced and metastatic cancers, but we're going to continue that discussion here. And as she mentioned, I am a metastatic breast cancer patient, also an advocate, and this topic is very important to me. And I know it is to the rest of the panelists. So I was wondering if the others could introduce themselves. Let's start with Lee. Maybe you can tell us a little bit about your personal diagnosis, when you were diagnosed, and where you're at now.
Okay, thanks, Christine. And thank you to the NCI for inviting me to speak on this panel. What very, very important topic for those of us who are or have been metastatic. So my name is Lee Jones. I live in Arlington, Virginia, right outside of Washington, D.C. In 2004, at the age of 55, I was diagnosed with metastatic colon cancer with 5 metastases in my liver. I've now learned that means that I was unresectable. I didn't know that at the time, but I know that now. So, there's a topic called oligometastatic cancer. I was not oligometastatic because I was not resectable. So after 2.5 years of going through treatment and then having liver resection in July of 2006, I then had 5 years of surveillance where I was getting CAT scans every 3 months, every 6 months, and then one last time. Since 2011, I have been very fortunate to be cancer-free as far as I know. I call myself cured, although my doctors would find no evidence of disease. So considering the fact that when I was diagnosed in 2004, the 5-year survival rate was 7%, I'm obviously very lucky to be here, but I have lived with metastatic cancer and now I've lived without metastatic cancer. So
thank you,
that's
Lee.
my story.
Yeah, that's a great, and we were very happy to bring you onto the panel because I think we're going to see the whole breadth, the spectrum of metastatic patients that exist. So you're kind of one of our exceptional survivors. Let's go to Bethany.
Hey, so my name is Bethany Abbott. I live in Nashua, New Hampshire, so I am about an hour north of Boston. I was diagnosed with stage 4 neuroendocrine cancer in August of 2018. When I say neuroendocrine cancer, most people have no idea what I'm talking about. Our ribbon is a zebra. I wore this because people have probably never seen the zebra ribbon either. So you have neuroendocrine cells all throughout your body, and those cells in organs, and those cells can actually get cancer. So I was first diagnosed in my appendix. They removed that and then did a PET scan I had never heard of before called a gallium 68 PET scan. So it's different than the normal PET scan, and that found it in my pancreas, which was also spread to my liver and my lymph nodes. So I had 4 months of some hormone treatments and then had surgery in July of 2019 that removed the remaining tumors. So from my lymph nodes and had my liver resectioned. So now I'm in the surveillance phase and will be the rest of my life. I'm kind of a weird edge case. I was diagnosed at 30 and with multiple primaries. So they did genetic testing and all kinds of things. Luckily, I was close enough to Boston that I can see some top doctors who actually are specialists in my kind of cancer. So I've been no evidence of disease, living a pretty normal life. I run half marathons. I work full time as an information security engineer. So hopefully you don't hear any like weird noises of like me getting paged or anything in the background in this meeting. And I was able to work full time while I was going through everything other than some breaks for surgeries.
That's great, Bethany, and we're very happy you're here. We know you're juggling a lot, as many metastatic patients do. So thank you, and I'm really glad you're wearing that ribbon. I'm glad we can see. And we're going to touch on rare cancers for sure. Leslie, can you go ahead and introduce yourself?
Absolutely. So thank you so much for inviting me to this conversation. My name is Leslie Glenn. I am a proud member of the BIPOC community. I identify as a Native Hawaiian. I was born and raised in the islands, but currently live in the Rogue Valley in Southern Oregon. I was diagnosed with hormone positive metastatic breast cancer in 2013 and am currently on my third line of treatment. So I have been metastatic for going on 8.5 years now, and I am hormone positive. So I have metastatic disease to my bones, and I do understand that I am very fortunate to still be here 8.5 years later when the stats show that the average lifespan of those of us living with metastatic breast cancer is basically 3 years. So thank you.
Thanks so much, Leslie. I wanted to touch on something that was mentioned in the talk about the word survivor and how it sometimes rubs people the wrong way. I'm curious, let's start with Lee, who has been surviving the longest with metastatic disease. How do you feel about the word, Lee? Oh, I think you're muted.
A term that we never heard before the pandemic. I think you're on mute, right? Who would have thought to say that to anybody? I'm happy to call myself a survivor because I feel I truly am. I'm also happy to call myself cured, which is probably not a medical term, but makes me feel better. So I have no problems with it, but I think everyone should be able to, use whatever term is most meaningful to them or least harmful to them, however they want to interpret it. I mean, we talk about this in all areas of society today. We need to treat people the way they want to be treated and talk about them the way they want to be talked about. And I think that's certainly fair and reasonable for everybody in any kind of terms.
Right. And I know, Bethany, you have your own term that you like to use.
Yeah, so I asked Christine if I could say this because I wasn't sure. And I also always take notes at these meetings and this. So this is what I go by, cancer badass, because I have met multiple people who don't want to be called a survivor, as was talked about. And I struggled with it because I thought a survivor means you're done. And I'm never going to be done. They're telling me my cancer is going to come back. It's just a matter of time, which is why I'm going to be surveyed forever. But I have yet to meet anyone who does not want to be called a badass. So I think we should be called cancer badasses.
I mean, I think you earned it. I think we all have. Yeah, and that is something what you're talking about now, which is essentially never ending your treatment. So I'm also stable, no evidence of disease, but I still have a port in my chest. I get infusions every 3 weeks. I'm on hormone therapy, and I'm dealing with a lot of side effects. And I think why this panel is so important is that I understand that oncologists are there to treat your cancer, right? We're there to keep you alive. And sometimes what happens is when you live, they're like, okay, it's done now. And the truth is like we want to live longer, but we also want to live better. We want to have a good quality of life. And so I think the symptom management is a huge issue within our community because we are on treatments indefinitely. And Leslie has a wonderful program, an organization that she has founded to help patients, manage these symptoms with integrative approaches. So Leslie, I don't know if you want to talk a little bit about Project Life. I'm doing the plug for you
Yeah.
because it's so wonderful.
Thank you so much, Christine. Yeah, so I started Project Life as I am an Elevate ambassador with the NCCS and trying to figure out what my project was going to be as part of this amazing opportunity. And for so long within the metastatic breast cancer community, we have noticed, and I have noticed, that there were a lot of gatekeepers at these survivorship programs where we were not invited in. We were literally left out because they didn't know how to address those of us that were facing our mortality. And so I took this opportunity to say, all right, well, if nobody else is going to do it, then I'm going to do it. And so it took about 8 months of really brainstorming and having focus groups with the community of what they really wanted. And so we formulated Project Life and we just launched it on March 1st. And we have had an amazing response, an overwhelming response from the metastatic breast cancer community to what our organization is providing. And so basically, it is a virtual wellness house where those that are living with metastatic breast cancer and their caregivers, and I want to emphasize that, is that we see the caregivers as part of our what we are going through. So we know that they need as many resources as possible, as much as we do for those of us that are living with it. So we do a lot of integrative programs such as therapeutic art, we have exercise, we have mindfulness. We do a whole thing about how green spaces helps with anxiety and depression. We have a legal opportunity and just places for patients to come. We have live virtual cooking classes. And what I have found as we have been doing this is that what the patients appreciate the most and the caregivers is that they finally have a place where they feel like they belong. So they are able to be in this space, they are able to be who they are able to express their frustrations, their joys, their really crappy days, and no one is going to try and fix them, or no one is going to put up a whole bunch of slides for a webinar and say, do A, B, C, and D. And as a metastatic breast cancer patient myself, those are the spaces that I am always looking for. Where am I going to get the best support for how I am living and what I am living with, knowing that at any point in time, cancer may progress for me, and all the challenges that come up with that. So as far as the survivorship thing, I would say that it is definitely what I have found doing focus groups. It's definitely a personal preference. I don't mind being called a survivor, though sometimes I feel like calling my survivor with a metastatic diagnosis kind of makes me feel like I'm desperate to survive. So I like Thriver. I understand that I'm surviving every single day with my disease, but I also want to thrive with the best quality of life that I possibly can. Thank you.
Great, thanks, Leslie. Yeah, so I think I really wanted Leslie to highlight some of the programs that she uses because I think a lot of doctors refer patients to support groups. And a support group isn't necessarily for everybody. And some of us, I was terrified to go to a support group because I was doing really well and I was afraid to see people not doing well. And so there's a lot of different ways that we can provide care to patients to help manage their symptoms. So I just wanted to highlight some of the unique programs that Leslie offers through her organization. And both Leslie and I are breast cancer patients, and so we recognize that we are overrepresented in a lot of these discussions. So it was very interesting talking to both Bethany and Lee, and to see, I love the fact that you're wearing that ribbon, Bethany, because everybody knows breast cancer. Everybody sees a pink ribbon and they know what that is. And so I was wondering if you could talk a little bit about the challenges of having a rare cancer and also of being diagnosed so young. You were 30, is that correct?
Yeah, so I got diagnosed at 30. I actually was sick for over 9 months before I got my diagnosis. I was running a half marathon. Actually, it was like I was in Vegas for a half marathon when my symptoms really started, and I thought I was just getting like weird food poisoning. I was vomiting every day. I came home and my symptoms were continuing. I was tired and vomiting every day. I saw my PCP. She told me that it was depression, have some medication, and it will stop. And I was like, I don't think I believe her, but I'm just gonna, okay, I'll take this medication. Um, of course, it didn't help. And I asked for a referral to a GI doctor, like I had to ask. So our GI doctor, she did a bunch of tests. Um, they pretty much told me I had IBS, so like irritable bowel syndrome. We don't really know what's causing it. Yeah, we're just going to keep giving you this medication that will make you less nauseous and good luck was pretty much what I was told. And this was with my care in New Hampshire. It had been months and months, and I was just like, I don't believe these people. Like, something is really wrong with me, and no one is listening to me. I get I'm 30, I run half marathons, I look healthy, but something is wrong. So I ended up making the decision. So that started in November. So I ended up making the decision in March of the following year to go to Boston and see a GI doctor because I was like, someone needs to tell me something's wrong. So they referred me to a neurologist to check if it was neurological why I was vomiting. Saw another GI doctor at that hospital. They finally did a CT scan. Why it took this long, who knows? And saw something on my appendix and said, "Oh, we just need to remove it at some point." So I was actually getting married a couple months later. Was like, "Okay, I'll just put it off." Nobody gave me like a big, "Oh, you need to do this right away." Um, I ended up taking, it took 10 days after my surgery to get a phone call that told me that we found this tumor, and I was told it was the good kind of cancer. And at that point, I decided I was done with that doctor. No one's going to tell me cancer is good, no matter what it is. So then I ended up going to a specialty hospital in Boston that focuses on cancer, and found a doctor. And the surgeon had told me, like, we got it all. And I was like, how do you know you got it all when you didn't do any scans? Um, so they ended up doing another scan and finding it was in my pancreas and my liver. So I went through 6 doctors to get diagnosed in less than a year. And every time I had to make the decision that I did not trust this person with medical degrees from the top universities, I was like, there is something wrong. You're going to listen to me. I know I'm 30, but you're going to listen. And finally was able to set up a care team myself of people that could help. Um, I had never didn't even know what a neuroendocrine cell was when I got diagnosed. Now I like bought a textbook about neuroendocrine cells. I was mentioning when I talked to Christine earlier. Like I have become an expert in this. And actually like who I got most of my information is another patient advocate that lives in the UK that has neuroendocrine cancer. Um, there's like you'll hear the wrong terms being used. You get diagnosed with carcinoid cancer, which is getting phased out as a term. And you just have to become an expert in your kind of cancer. When you have a rare cancer. Like, if I go to urgent care, they look at my thing and they're like, you have stage 4 cancer? what is this? Is this in your brain? And I'm like, I know it says neuro, but it's not in my brain. And then I tell somebody it's in my pancreas or was, and they're like, oh my God, you have pancreatic cancer? How are you alive right now? And I have to explain again, it's a different kind of cancer. So it's something no one's ever heard of, including myself, when I got diagnosed.
Well, I'm so glad that you are such a strong advocate for yourself because I mean, this is just a shining example of like how patients can really advocate on their own behalf. But at the same time, it's disappointing that you had to work so hard to get the diagnosis. And we see this a lot with young breast cancer patients. I know in the same thing, Lee, I would love for you to talk a little bit about in the colorectal community. I know that, there are definitely stigmas with you, as you mentioned, that younger people are getting diagnosed now, and there are these issues with doctors sort of saying, "Well, you look healthy, so and you're young." And for me, I didn't have any history of breast cancer, but could you talk a little bit about those challenges in the colorectal cancer community?
Yeah, thanks. It's a great question. Uh, Typically, when somebody age 40 goes in and they have some symptoms of what could be colorectal cancer, their primary care physicians would say, oh, you're under age 50, you're too young for colorectal cancer. So, you know, as Bethany had said, well, assume it's irritable bowel syndrome or something like that. We'll give you, some medication and you can go away. And so by the time they finally get a diagnosis, they're oftentimes at late stage, they're oftentimes metastatic, and they don't know how they got there. And there's this sort of communication gap. Gastroenterologists know that a lot of people are being diagnosed at a younger age, but that hasn't necessarily reached all the primary care physicians, which is our first contact usually with the healthcare system. We have someone we see regularly. We don't get into a gastroenterologist other than by referral. So it's, I think those numbers have been increasing, something like 2% a year. So over 50 has been going down because of colonoscopies and screening methods. Under age 50 has been going up. And now there's a draft recommendation to lower that screening age from 50 to 45, which I think will get accepted and will be in place. But even 45 is too old. I've been at meetings where I've sat next to people who got diagnosed in their teens and early 20s and early 30s. So the thing is, so I have two sons in their early 30s. They're not old enough to get screened yet because they're not 40, which is the screening recommendation. But I have to try to tell them, here are the symptoms to watch out for. If you have these symptoms, you need to go into your doctor. You need to insist on getting screened. You need to tell them that your father had colon cancer and don't take no for an answer. I think that's it. It's not a guarantee that it's colon cancer, or more commonly rectal cancer for the younger people, but it has to be considered as a possibility and ruled out, before they're just sent home with nothing.
Right. I'm glad you actually brought up the primary care doctor role. We had a question from the audience about their role in your care, and maybe we can let's start with Leslie. If you can talk about the role of your primary care doctor, if any.
Yeah, so my primary care physician, I just changed to another one, has previously, he had no connection with my cancer treatment at all. So there was no connect with my oncology team. And he was more disengaged with what I was going through as a metastatic breast cancer patient. So I found that that was very frustrating for me when I would go in to see him, because I also ended up with hypertension because of my diagnosis, so getting treated for high blood pressure as well. And I just found that, I wasn't connecting with him at a certain level. He wasn't fully listening to me. And I finally said, okay, this is enough. I need to find somebody that's going to actually listen to me and want to kind of follow along with what I am dealing with while living with this diagnosis. So my current primary care nurse practitioner actually She is fabulous. When I first met with her, she connected right away with my oncology team. She was able to get into my records and really look it over from the time that I was diagnosed to 8.5 years later. And my first sit down with her was an hour and a half. And we talked about from the time that I was diagnosed into where I am now. And we went through what my side effects were, the challenges that I had along the way. And we formulated this plan for me that was never ever brought up, even by my oncology team, as far as like a survivorship plan, which I think is very lacking within the metastatic community as a whole. We need survivorship plans. And so I think that was, I don't think, I know that that was the best decision I made, was to to look at my diagnosis as holistic, as this whole team, that we're all working together, and I'm working with my team. I'm more of the quarterback, and telling them these are the plays that I want to do. What can we do together? So very happy with where I am right now in primary care.
That's great. And I wanted to mention there's some really great panels that are going to be coming in during this conference over the next 2 days, one of which is healthcare delivery issues, as well as surveillance research and symptom management. So I'm excited to actually see these panels as well, and I encourage others to join. We also got one very good question, and I'm going to just throw it out there, whoever wants to answer it. Could you comment on when survivorship should actually be introduced into the conversation with the patient survivor? So this is a tricky question, because I'm trying to imagine the day that I got that diagnosis of, you have breast cancer. Do I really want somebody to be talking to me about surviving? Like, I just don't know. What do you guys think? When is it appropriate?
That is a really good question, particularly because with metastatic cancer, I think the thought in the oncologist's mind is this patient's not going to survive. And, we hear that all the time. That's why we're not in a lot of studies, because, well, they may not live through the entire study, unless it's a drug study, but certainly for quality of life types of studies. I actually never raised that question, even though, of course, after my colonoscopy, I went and checked up with Dr. Google, and Dr. Google said 7% 5-year survival rate. But my thought process was, even if no one has ever survived this before, I could be the first one. If two had survived, I could be the third one. So it was never really an issue for me. But actually, my oncologist and I never really talked about it. We never talked about whether the chemo treatment was for curative purposes, which I understand now is something that they think about, because I said I was not resectable. So as far as the healthcare community looked at it, it was a fatal disease. It was uncurable. And with colon cancer, uncurable means fatal, because eventually then, your liver, your lungs, it ends up just going from organ to organ.
So what came to my mind right away was when I was diagnosed metastatic, was my oncologist told me, Leslie, you are 99.9999% incurable. However, my goal is to treat you and to make sure that you have the best quality of life for as long as we can. And so I think in that way, she already introduced survivorship to me without actually using that word. So she was laying the foundation for what I was going to be facing for the rest of my life, but letting me know that we have this goal, that we want you to live as long as you possibly can.
Yeah, I was gonna say for me, like survivorship wasn't a term that was ever introduced to me. Like I just started getting the emails from my cancer center that were like, come to our survivorship webinars. I was like, I don't know what list I ended up on. My oncologist pretty much was like, I'll just see you forever. Like that's how it's working. Like every 3 to 6 months I get a scan. I would say for my I don't call cancer a journey also. I call it a dumpster fire. So for my cancer, dumpster fire. My survivorship came from mental health resources. So I know this is something we're going to touch on a bit, and other sessions are about
Touch
it.
on it now. I was going to bring it
Okay.
up. Go for it. Mental
Um,
health is a big issue that we want to talk about. So go
okay.
ahead.
So that's how I feel like because I thought cancer survivor meant you were done, and I was told I was never done. And my therapist told me the day you're diagnosed with cancer, you become a survivor, and that was mentioned earlier today too. But what I say is when people get diagnosed with cancer, the whoever diagnosed you, say it's a PCP, oncologist, whatever, your diagnosis with cancer should come with a referral to a psychiatrist and a referral to a therapist or social worker. I feel like that right now it's on the patient to say, oh, I'm having a hard time dealing with this, which when you are diagnosed, I was 30, I was diagnosed with it. No one would tell me like outcomes because the scan was relatively new, FDA approved. I was a weird edge case. I mean, I Googled it. Like Lee said, I went to Dr. Google. Dr. Google told me I had a 27% survival rate. I'm coming up on 3 years. At 5 years, I plan on running a marathon with a little extra, so that way I run 27 miles to beat my 27%. Um, but I got to this point because of mental health resources, not only a support group for young adults, but also online support groups for young adults, support groups for neuroendocrine patients, although a lot of them are diagnosed at 60. So they're looking at, oh, I decided to retire because I got diagnosed. And I'm like, I'm just starting my career of retirement. I'm not doing that. So I found more of a place in the young adult community, which is usually like 18 to 40-year-olds. But I think like any doctor that's listening right now, if you ever diagnose a patient, you should give them a referral to mental health resources. They should not have to seek out that on their own when they're pulling up stats that say, I'm not going to be here in a couple of years, maybe, which I have my own opinion about how wrong all those stats are. But we should like hold our healthcare providers accountable that they should be the ones that are doing this work for us, not us who are trying to struggle with, I just want to sleep all day because I don't feel good.
Yeah,
One
it's
thing to
an
add on the early discussion, it's also, so when I finished my 5-year surveillance, basically, they pushed me out of the oncology nest, which I'd been in for 7.5 years, out into the real world and said, well, there's really nothing more we can do for you. Even additional scans aren't shown to have any benefit. We can give you a scan again if you want it, but there's no reason to do that. And so you're sort of cast adrift. What do I do now? And they were thrown back into primary care with all the problems we've talked about, and the fact that nobody tells us about potential late effects. Whether they're potential cardiac issues, whether it's long-term neuropathy, whether it's secondary cancers or cancer recurrences. I do have to get a colonoscopy every 3 years, so that's the one connection I still have. But sort of a sad commentary is that I've kept my Metaport in because it keeps me connected to that environment. The years that I hated to go in there to the infusion center, now it's like I can go in there and I feel okay about that. Get my port flushed every 2 or 3 months, and I'm fine, which is kind of sad to be trying to stay connected to that world.
Yeah. Um, I wanted to keep talking a little bit more about the mental health and also financial health. This is, an ongoing issue. Financial toxicity is a major problem for patients. So we're going to touch on that. But I want to talk about, it seemed to me that each cancer community has a unique issues in terms of mental health. I can speak for the breast cancer community, and Leslie, you can chime in, but there is a lot of depression and anxiety around relationships. This is one of the most common questions I think I see in the private Facebook groups are, should I leave my husband? Should I allow my husband to have another partner? Sexual dysfunction is like a huge I think in breast cancer is probably the number one concern when it comes to symptom management. If you're a hormone receptor positive patient, that means you're going to be receiving therapy that's shutting off your estrogen, and it causes lots of side effects. So I know that is a major issue. And I think what Bethany said about bringing in a therapist, I mean, I've seen many relationships dissolve because they don't have the help and support that they need to get them through a trauma like cancer. Leslie, I didn't know if you had any other points to add in terms of in the breast cancer community, but I know that there's a lot of depression, anxiety around relationships.
Yeah, absolutely. I mean, I think that not only is it a mental health type of thing, as well as physical, for those of us that are going through these treatments, and body image, you know, um, for the women that have gone through, breast altering surgery. I chose to have a lumpectomy, but that, comes with a different source of body image where, one is bigger than the other. And we just, recently had a conversation on the Project Life platform with Dr. Sharon Bober, who is a psychotherapist from Dana-Farber, about, the sexual impact and intimacy challenges for those of us living with metastatic breast cancer. And it was a small group of women and we all were really open, and we deal with, the guilt part of it, of not being able to be as intimate as maybe we were, or for those of us that are single, will I ever go on a date again? Or will I ever, have a relationship where my partner might understand the challenges that I am facing? And especially for women and our sexuality, um, it plays a big part into our mental health. And I totally agree with Bethany. I mean, you should have a therapist right off the bat. Um, at least, being given the option to go to one. So,
And I think
yeah.
it's tough, like when you get that diagnosis, um, you're immediately changed. And like, it's something that people don't understand. Like, even if you're a researcher or a doctor, like you still don't understand what it's like when somebody gets that call that says you have cancer. Like, your life immediately changes. You are no longer the person you are before cancer.
Mhm.
And how, like, people in your life, including significant others, family, etc., expect you to be that person. And struggling with that, like, my therapist is also a cancer badass. So she got it when I was like, I don't have to explain this feeling to you. Or like the constant anxiety that comes up. I get scans every 3 to 6 months, and like scanxiety is real. I have a shirt that says scanxiety because it's a real thing that happens, of like, how do you stop living your life to the next scan? Like, stop planning your life only every 3 to 6 months out.
Can
I
you
think even worse than getting a diagnosis of cancer is stage 4 cancer, metastatic cancer. Because it used to be, especially if it's in your liver, that's a death sentence.
Mm-hmm. Yeah, we actually had a question about the impact of scans, so I'm glad you touched on it. I mean, I can say I always think I don't have it, and then all of a sudden my scans are coming up, and all of a sudden I'm having headaches, and I'm wondering if I have brain metastasis, and it happens every single time. So it's a real thing. It still happens. I still want to be scanned. It doesn't, for me, it's worth the anxiety because I want to make sure that I'm still clear of cancer.
Hmm.
So I'm glad you touched on that, Bethany. I also we've had a few questions about the caregiver role, which I think is a really, really important piece that I want to just touch on, which is, I think, I don't know, I don't even know if this is the right term for it, but have you heard of that circle theory where the patient is at the center of the circle and then there's like there's like an outer circle, which would maybe be like husband, children, immediate family, and then it keeps going out like that. And the concept is that you never go into the circle to get your support. So caregivers should not be relying on the patient themselves. We see this a lot. We see a lot of times where caregivers are explaining how upset they are to their partner for their cancer diagnosis, but really they need to be going outside of that circle. They need to make sure that they're seeking support, but that it's not impacting the patient. Do you guys have any suggestions? One of the questions was about how to engage caregivers, which I think is a really good question. I don't actually have a great answer for it, but does anybody have any comments on that?
I think you
Um,
just ask. I think that, I would have appreciated it when, I was going through all of these. Well, I mostly go to my treatments by myself now because I'm 8 years out. I don't need my husband to come with me. But, in the beginning parts of it, you know, I wish somebody would have asked him, "How are you doing?" Because all the focus was on me. And I heard a story once, of a gentleman, who had brain cancer, and he was going in for his treatment. And the same in my cancer center, well, they're not doing it now because of COVID, but you could have a massage after you had your treatment. And so they asked him, "Do you want a massage after your treatment?" And he said, "No, but you can give that massage to my wife because she probably needs it more than I do." And that just really stuck to me. I'm like, oh my gosh, that is so true. She probably really does need a massage. And the same with, having a husband as a caregiver, and they're trying to, make everything better and make sure your environment is good. And my husband wanted to make sure that the house was always clean for me. Um, and what kind of support would he have wanted? And didn't anybody ever ask? And, you know, from my perspective, as someone that lives with the disease with caregivers, it's like, just ask. They're going to tell you yes or no. Um,
Yeah, I think it's one of the number one reasons. We had a question about clinical trial participation, and a lot of people have there's a lot of reasons why people don't participate in trials, but one of the biggest ones is that people don't tell them about it. So it's the same thing. If you want to engage a caregiver, ask the patient, do they have somebody at home that would be, that would be interested in getting support? I think it's a really good point. It's very simple. Sometimes the simplest solutions are the best ones. So did anybody else have any other comments? Go ahead,
Well,
Lee.
and if you have a need or an issue, like I was feeling depressed, so I told my oncologist that, and he prescribed an antidepressant for me. I mean, so don't, and if you're in pain, you need to tell your physician and get your pain dealt with. It's not a matter of, oh, I need to be strong and I can gut through this. If you have an issue, you need to tell people because there may be an easy solution for that, for nausea, vomiting, pain, depression, anxiety. There are medications. And I remember I was taking pain pills after my liver surgery, and I actually asked a psychiatrist, "Am I getting addicted to these?" He said, "No, you need them."
mm.
This is not a question of addiction. This is a question of, are you in pain? Yes, take your pain pills.
Yeah, I was just going to add about caregivers is so my treatment's at Dana-Farber, and they just started a caregiver newsletter that goes out. So like, they sent it out to the patients and said, it might just be for young adults. I get both. I get all kinds of stuff coming in. And it said like, forward this email to your caregiver so they can sign up. And just that, like all I had to do was click forward and forward it on. Um, so it didn't require a lot of work for me. And then my caregiver was able to sign up and get information about like he went to a caregiver 101 webinar, which I was like, this would have been great 3 years ago. Um,
Yes.
but just the more available those things are now, like everything's becoming online because of the pandemic. But just something as simple as that, like forward this to your caregiver. So that's all I had to do, and then it was up to them what they wanted to go forward with.
Yes, making it easy for we want to take the burden off of the patients. We are often burdened with not only managing our disease and dealing with our side effects, but helping everybody else around us as well. So I think that makes it, I think that's a very good solution. We had a good question that I actually want to answer it myself, and then I want to hear what you guys have to say. But the question was, what were the most challenging symptoms that you faced or are facing, and do you feel like they are being addressed? And for me, I just wanted to bring this up. I don't know if it's the most challenging, but it is a very difficult side effect of living with metastatic disease is that I lose so many people in my life. I have a lot of survivor's guilt. I don't know what to tell the mothers of the friends that I've lost, and there's not a whole lot of support out there for I mean, for patients who have survived and now, are watching people around them, and I feel like I'm in my 80s or 90s because I'm losing. I just lost a friend this weekend, so it is a very challenging, difficult, especially when you're in advocacy. You're around it all the time, and so that is something that I've had to learn how to, how do I deal with death and dying in people who should had no business dying in their 30s and 40s, like no business. So I just wanted to bring that up as a issue among, especially in breast cancer, where we do see a lot of survivor, a lot of long-term survivors. Did you guys have any others to add? Any challenging symptoms that, are they being addressed, not being addressed?
And I'm so sorry this time has flown. We do have about 5 minutes left at
Oh,
this
that went fast.
moment.
Thank
Getting
you.
into such an important topic. I'll turn my video off.
Great, thank you. That went really fast. Maybe one of you can answer
I would
that.
just say for me, peripheral neuropathy, and I think for a lot of people, a standard treatment for colorectal cancer is oxaliplatin, which has issue with peripheral neuropathy. For some people, it's very long lasting. For me, it fortunately went away, but it ends up being probably the most irritating one because it's one that we don't know how to really deal with.
Yeah.
Even going outside in the winter, any exposed skin feels like it's burning off. Can't reach into the refrigerator without your hands burning. So
Yep. Yep.
I would say, yeah, I was gonna say for me, well, I was vomiting every day when I was sick at my sickest. So like that was interesting to learn like where to pull over to throw up when you're driving. So that wasn't handled very well. But I would say now I deal with still fatigue, and like the stress and fatigue, I would say, are the biggest for me. Also, I work full time, so that throws its own wrench into things. Which there's some people that decide to work full time, some don't. I would say if you're in the US, there's things that you can look at, there's protections in place. I was very fortunate at my company and they're very flexible. I worked from home before the pandemic. But that's something I've heard a lot from young adults, that like, how do you deal with the fatigue when you need a lunchtime nap? How do you explain that to your boss?
Yeah. Yep, that's a good one. Fatigue, I think, affects all of us. Leslie, did you have any others to add?
Yeah, so I totally agree with, what Christine says, and I'll just give a visual of, I've told people that it's like all of us in the metastatic breast cancer community are in this revolving door, and at certain points, somebody leaves the roundabout going around because their time was up, unfortunately. So totally understand that. But if I can say this, with everything that's going to be discussed in the next couple of days is, if you are planning on starting something for the metastatic community, please include those that are living. Have us at the table to tell you exactly what we need, because we are the experts in our diagnoses and don't leave our voices out.
Agreed. Yeah, we'll do the work for you. Like we already know what our needs are. And I also encourage you to get a diverse, patient population, whatever you're studying, making sure that you're including patients of different cancer types, different ages. There's a wide spectrum. And I forgot to mention this at the beginning, but Doug Sparling was supposed to join us. He was unable to, and due to health issues. So, you can see that whole spectrum of where we're at. We've got people like Lee who've been living now for over a decade with metastatic disease. And then some of us are here in the middle. And then we've got people who are really sick and some people in hospice. So just being cognizant and aware that each person is, it's an N of one patient. So, not to apply general stereotypes. And I think that, this discussion is just so important for not only us, but for the doctors treating us. I mean, they need to hear what is important to our community. I think we only have 1 more minute. So one of the last questions I think we have is, how do we get the word out about self-advocacy to survivors, badass folks, and thrivers? So we're going to use all the different terms, but how do we do this? I mean, it is difficult to help people understand that there's white coat syndrome, where you see a doctor and you think, I have to listen to everything this doctor says. So what are some of the tips and tricks we can offer to patients?
I think doctors can almost prescribe it.
Mm.
Say, you know, in your treatment, here are some resources you can use, as they talked about psychiatric resources, nutrition resources, but also quality of life and advocacy resources. Some people really enjoy doing that sort of thing. Other people tend not to, but make it an option.
Mhm.
Yeah, and I think just like telling stories. So like I didn't know if I wanted to tell people I had stage 4 cancer because I was like, what is going to happen in my career? And now, anytime I talk to anybody who says they have a medical problem, like, let me tell you a story.
Mhm.
And doing things like this. So just sharing with patients um, that there are people out there who have done this and are here because of self-advocacy.
Mhm. Yeah, I think that's a really good point. I think we're out of time. We never touched on a few of the points I wanted to, but that's okay. It was a good discussion. Thank you for all of you joining us today. I know you all have busy lives, so I'm very
Thank you.
grateful to have you here.